Thank you. Okay, I was told to keep this to 15 minutes, and so I'm going to tell you everything I know in 15 minutes, and I may have to fill a little bit. Anyway, as soon as I find the page down button. Now, what I wanted to say was this is sort of a little bit of a preview to the presentation that I plan on doing at the World Quality Congress. Actually, I'm going to be doing it at the ICQI, which is the co-joint conference with Quality Management Division, and they are interested in sort of marrying up quality management with statistics for more of a technical view of management. And I'll talk a little more about super tools. But what I really want to talk about now is how many of you here have been involved at some point with Six Sigma? Good, great. Everybody knows DMAIC then? Okay, think of A on steroids. Okay, think of A on steroids. What normally we have done for the last 10 years or 15 years in Six Sigma is we go DMA and we get to A and we go, collect some data. Do we have any data? No. Well, let's get some data. Where are we going to get it? Well, let's go do a quick observation and collect some data points, and then we'll make a Pareto chart. And that'll be analysis, right? Well, unfortunately, the problems that we're left with now are the hard ones. And I've told the story many times about one of the presidential cabinet members that said, well, we don't have any easy problems anymore. We've solved all of them. All we're left with is the hard ones. And that is true. They're multivariate. They're nonlinear. They're dynamic. They're complex. And the thing that's interesting now is we didn't used to have enough data. Now we got way too much. With the electronic medical health records, electronic medical records, all of the automated systems, the financial data, the clinical data, now we can analyze things 15 different ways. But then the simple tools don't really help us much. So I want to just show you a little bit about how that can work. And of course, if you know me, then you know I'm liable to talk about Peyton Manning at least once in 15 minutes. So I'm going to do that. Some of you, how many football fans we got? We got any football fans? We got one or two. Yeah. Everybody know what passer rating is? It's the thing they've used for years to say which quarterbacks are the best. Well, if you look at the passer rating, and this was after week 8, I didn't update it yesterday, okay? But if you look at the passer rating, and you can't read any of that, and that's okay, but I'll tell you now, Peyton Manning is up at the top of the list, which makes sense, I think. I mean, I know I'm biased, but if you think about it a minute, if you look at what he's done so far this year, you'd say, yeah, that's reasonable. I don't know that it's right, but it's not obviously wrong. Now, but on the other hand, when you look at this, and you can't see it hardly, but right down at the very bottom at number 25 is a fellow named Andrew Luck. And you say, are you trying to tell me there are 24 quarterbacks better than Andrew Luck? Can you find, how many would you trade Andrew Luck for? Okay, and this is the problem with this simplistic, simple formula that you can run with about 4 or 5 factors in Excel to compute this. And it's not very accurate, and everybody knows that. So several years ago, ESPN started a new rating system, and all they did was look at every play for 3 years for every player and use that to build a model that they could use to rate quarterbacks based on how they impact the game. Rather than a simple statistic, now it's a complex dynamic statistic and a giant computer algorithm. And guess who's number 1? Yeah, right, but guess where Andrew is? Now, the whole point of all of this is 2 things. Number 1, something called predictive analytics, or data science, or business analytics, or it's got a whole bunch of names, is coming like a freight train. Okay? Operational analysis, whatever you want to call it. It's coming like a freight train. And so the whole deal is that we're beginning to use these tools to make better assessments of what's really going on and better predictions about what's going to happen next, and use that giant volume of data. Okay? And this is a simple example. There's another interesting sports example that I will give you, and that is Brad Stevens out at Butler uses it and is one of the people that is highlighted in IBM's ads on predictive analytics. Isn't that cool? I think that's just really cool. Anybody baseball fan? Anybody notice that this year that instead of shifting the infield around for one or two players in the league, they were shifting the infield for almost every player? Didn't see that? Pay attention. You'll look at it and you'll say, wait a minute, where's the shortstop? And the answer is he's out there behind second base sometimes. And the reason for that is they now have analytics on every batter, and they know where they hit the ball. And when they were asked about it, Joe Madden, the manager for Tampa Bay, said, why would I put players where they don't hit the ball? Remember that, okay? That's an interesting. Okay, so we begin to look at it, and one of the things that in healthcare that everybody is really concerned about is length of stay. And we can talk about length of stay in the emergency room or length of stay in the hospital. Everybody focuses in on that as the key, and the reason for that is really simple. If your average length of stay is 4 days, and you could somehow reduce it to 3 days, what would you have done? Well, number one, you would have reduced your expense of treating that patient by about, how much? 25%? You would have increased your capacity because now, instead of being able to do 3 patients in a room, 3 divided into 30 is 10. Instead of being able to do 7 or 8 patients a month in a room, you can do 10. Okay, so you reduce the cost, you increase the capacity. Do you know how much? You know how much it costs to build a hospital room. We know how much it costs down at Franciscan because we just built 445 new ones. Okay, 445 beds, plus or minus, I'm not sure exactly. About 60 in the new emergency room. And we're out of space. And I don't think we're going to get to build more right away. So what do we have to do? And the answer is we have to reduce. So we had a big deal. We were looking at length of stay, and this data is from the emergency room. And I'm not going to show you this for very long. And if you put this on the web, I may have to have a discussion with you about putting that on the web. Okay, but I don't think you can tell much from it, but anyway, here we go. But when you look at a histogram, you say, well, those are the daily average length of stays in the emergency room. And you look at it and say, ugh, that doesn't tell me much, does it? I mean, it's not normal. You wouldn't really expect length of stay data to be normal. It's probably right skewed, but we really can't tell much from it. It's fairly well behaved. So we jumped ahead and said, well, let's look at a trend chart. So we looked at a trend chart and we said, ooh, look, there are 3 days that are really way out there. Well, it turns out they're February, March, and February. This is 5 years worth of data. And these are monthly averages. So, and what we looked at, we said, flu, flu, flu. Right? And you said, okay, but where are 2010 and 2011? Didn't we have flu those years? And the answer is no, not so much. But when you look for them, you find them. It turns out they're down here. And so now you're saying, oh, I thought it might have been related to flu or special events, but it doesn't seem to be. So we began to look at another way to look at it. Remember what we said? Things are dynamic, they're complex, they change all the time. Okay, take a look at this. Now what we've got is we've got a series here of 1, 2, 3, 4, 5, 6 different processes. How many times did we change the way we routed patients and treated patients in the emergency room? 6 different times. Well, when you change the process, guess what happens? The times change. And this is, in fact, an individual X moving range control chart. And when you look at it this way, none of the points are out of control. So we had one process that was terribly ill-defined, but when we broke it down into the 6 real processes that were going on in sequence, they're all fairly well behaved. Now there's an interesting point here, and that is, you know, we started out over here with our baseline. We moved down to a rapid triage kind of a process, which really allowed us to split the flow and take the low acuity patients and move them in a split flow model and that kind of thing. But bless their hearts, Medicare came along, CMS came along and says, hey, we're not paying you for that. That's not emergency room treatment. So we had to redesign everything, and we stopped that, and it went back up. So the third period, it went back up. Then we tried another trick or two, and it changed the process and got it back down. But look what happened from here at 193 minutes average length of stay to here at 230. You know what this was? Electronic medical records. The electronic medical record came in and changed the way you do business and slowed us down. Okay? Now, it also, there's another piece here that's hidden in there. This is where we moved from the old emergency, the original emergency room, which was all of a couple years old, to a new one, which was twice as big. And everything was spread out, and it was beautiful, it was state-of-the-art, except we forgot that when you spread things out, it takes longer. So there's 2 functions there that changed at the same time, and they bounced this thing up by almost 40 minutes. Okay? Then about March this year, some of you may now be seeing some of the commercials for the Now ER, which is faster treatment. Yeah, okay, get to see the doctor quicker. And now the total, and our time from arrival, average time from arrival to seeing the doctor is now down in the vicinity of 20 minutes. And so when you look at that with the new process, we've gained almost all of it back again. We're down to about 200 minutes, which is 3 hours, 20 minutes. Okay? So when we look at it this way, you see things that you didn't see before. And one of the important things is when you're going to forecast based on this information, what do you forecast on? Do you forecast on all of the data, the 58 points? And the answer is absolutely not. You forecast on the last stable period. Okay? And so now we're looking at that, and here's an example of how you might do that, and this normal probability plot is an interesting way to, this is looking at all the data, and first of all, it is certainly not normal, and you probably shouldn't forecast on this, but I put it up there to show you, and there's the original average of 209, and now you see that when you look at just that final stable period, this is the average length of stay for the entire emergency room is now down in the vicinity of 230 minutes, but in that Now ER, it's down to about 200 minutes. Okay, so now that's what we're working on now to try to improve that. And guess where, I'll bet you can guess where the biggest factor is in slowing that down. Somebody, what?
Registration?
No. No, actually we've done great work on registration, got it smoothed out. The biggest thing is admitted patients being admitted to inpatient. You have to be able to find a room for them. And they slow things down, and they all, if they're being admitted, they're in a bed someplace. So they've got the emergency room full from mid-afternoon until late evening, early night. So, you know, And in fact, I don't think I brought that slide, but I've got this great slide that shows the relationship between how long it takes to get them from the floor, from the emergency room to a bed on the inpatient floor, and overall length of stay. And it's pretty amazing. R square is 54%. That's pretty high for a, anyway, fun stuff. Actually, I did bring it. We played with this, and this is sort of a fun thing. And this is a little bit of Minitab here. We use mostly Minitab or SPSS, and you may use different ones, different places. But the nice thing about this one is it allows you to look at a whole bunch of things and say, which of the factors, and I've only looked at 4 here, one of them is the count of all patients arriving. The second one is the count of the patients admitted. The third one is the bed request to room on the inpatient floor. And the last one is day of week. And you can look through there, and it basically tells you the biggest thing, the biggest factor is bed request to inpatient room at 54%. This is actually a best fit line with the control and with the uncertainty limits. And you can see the data fits very nicely, actually. So, you know, what you can do is you can look at a lot of different things. And of course, this comes out of data files that I've got that have 50, 60 variables and 7,000 patients a month since the middle of March. So, you know, you can look at those kind of things, and now you can begin to draw some pretty significant conclusions sometimes. The last thing that I'm going to mention, and I've just about used my time, the last thing I'm going to mention here is once you get going, how do you use this data? One of the best tricks for using this data is discrete event simulation, where you go in and you build a model of patient flow, for example, and you simulate, you use the inputs from your data and you simulate the performance and match it up to the actual performance you got. And then once you validate the model as actually working, then you can go in and say, what if I added another room? What if I changed one of the acute areas to one of the fast track areas? Or if I move some of those rooms over here? Or what if I could add a room, or add a doctor, or add a nurse? And so you can optimize the costs and the care levels and the throughput and that kind of thing. And you can do that even if it's not linear, and they aren't, even if there's lots of variability, and there is. And by the way, I don't think I brought any of the daily data, but we actually track a lot of those things on a daily basis. And it's like today, I sent a little note to the director of the emergency department and said, you might want to look at this one sort of went out of whack yesterday. And it's much easier to, and you all know this, it's much easier to go to find out what happened yesterday than it is to go out and say, what happened three months ago? Which is not hard, not easy. Okay, so business analytics. They sometimes call it business analytics, sometimes call it data science. Harvard Business Review has some great articles on data science. The one thing I will tell all of you is I saw a recent article on the Smarter Solutions website where one of their guys was saying, I think I found my next career after Master Black Belt. I'm going to go into predictive analytics because it's what we do. And that's what I'm trying to tell you is people with a quality background who have an analytic piece are much better suited to go into this work. You can train nurses for the rest of your life, and you're not going to get there with very many of them. And I like to tell people, would you like to train me for 6 months and have me be your surgeon? You know, I don't think that's a very good idea, and I don't think it works very well. And I've been doing this for 6 years, training nurses to do a little bit of statistics. And you know, what you can do is you can get them to the place where they know to come talk to you. And that's really enough, because 3 or 4 good statisticians will handle a big hospital. But there are lots of career opportunities out there to sort of branch out. And up until a year ago, they would say, no, we're different, we're healthcare. And now all of a sudden they're not saying that anymore. They're saying, oh, okay, let's talk about how we can do this. I have a great paper that I just got a day or 2 ago about a very similar sized hospital in Toledo and the success they've had. And if anybody is really interested, you can email me or talk to me, and I can probably get you the link to the paper, because I don't think I told everybody this, but their initial results were, after working on this the last 2 years, their 2-year savings is $70 million. Their investment was 7. That's 10 to 1. That's how we're going to save money, is by figuring out how to break down the silos and get groups. You know, my experience has been almost all of the delays are caused by hang-ups in information flow. We either don't know, or the people who need to know aren't being told by the people who do know. You know, and so it's an IT question. It's computers everywhere you look, but then again, that's the way the world is. It's happened in every industry, and now it's happening to healthcare. Any questions? And I almost did it in 15 minutes. Okay, thank you.